Hello everyone and welcome to Surgical Utopia. In today's video, we will be discussing about the neck dissections for surgical treatment of oral cancers. Neck dissections can be broadly classified into selective neck dissection or conservative neck dissections in which neck involvement is not there, and it can be classified as conservative neck dissection in which neck involvement is there. So basically, it involves comprehensive neck dissection, which is further classified into radical and modified radical neck dissections, depending on whatever structures are excised. So first, coming to the selective neck dissection, it is the one in which only lymphatic tissues are removed and all non-lymphatic tissues are spared, along with the sternocleidomastoid muscle, internal jugular vein, and spinal accessory nerve. The selective neck dissection is the one in which the selected levels of lymph nodes on the involved side of the neck is removed. And what all neck levels are to be dissected, it is decided on the basis of the common pattern according to which the cancerous cell will metastasize from its primary location to the lymph nodes. Further, the selective neck dissection is classified into 5 other neck dissections. The first one is the supraomohyoid neck dissection. In this, the lymph nodes in the level of 1, 2, and 3 are dissected and the submandibular salivary glands are removed. The supraomohyoid neck dissection is done in cases for squamous cell carcinoma of oral cavity. Then second type of neck dissection in selective neck dissection is the extended supraomohyoid neck dissection. In this, the lymph nodes in the level of 1, 2, 3 and 4 and the submandibular glands are removed. The extended supraomohyoid neck dissection is recommended for squamous cell carcinoma of lateral tongue. The third type is the anterolateral neck dissection or lateral neck dissection, in which the levels 2, 3 and 4 are removed. This is indicated in the patients with squamous cell carcinoma of larynx or pharynx, and dissection is done on the side of the lesion. It can be done bilaterally in case if the primary tumor crosses the midline. Also, in the cases where there is cancer of the oropharynx, the lateral neck dissection is to be done on both the sides, that is, it is done bilaterally in patients for whom the treatment plan for surgery is done, but in patients for whom the post-operative radiation therapy is indicated and it is planned, then the cases where oropharynx cancer is present, lateral neck dissection on the unilateral side or ipsilateral side is sufficient. If there is cancer of hypopharynx, then lateral neck dissection on both the sides of the neck will be done. In cases where there is cancer of hypopharynx and supraglottic and advanced glottic cancers are present, lateral neck dissection on both sides of the neck will be done. So to sum up this, the anterolateral neck dissection or the lateral neck dissection is recommended and indicated on the same side if there is cancer of larynx or pharynx, and if the primary cancer of larynx or pharynx crosses the midline, then lateral neck dissection is to be done on both sides of the neck. Whereas if there is cancer of oropharynx, then in patients for whom surgical treatment plan is done, then lateral neck dissection on both sides is indicated, but in patients in whom post-operative radiation therapy is planned, then lateral neck dissection on ipsilateral side is indicated. And in cases where there is cancer of hypopharynx and supraglottic, bilateral lateral neck dissection is indicated. The fourth type of selective neck dissection is posterolateral neck dissection. In this, the lymph nodes in the level 2, 3, 4 and 5 are removed and suboccipital and retroauricular lymph nodes are removed. The posterolateral neck dissection is carried out in cases where there is primary cutaneous malignancy of the posterior scalp. So if there is melanoma and squamous cell carcinoma of the posterior scalp, posterolateral neck dissection is recommended in N0 neck disease. The fifth type of selective neck dissection is the central compartment neck dissection. In this, the lymph nodes at the level of 6 in the prelaryngeal, pretracheal, and paratracheal regions are removed. So, the central compartment neck dissection is indicated in cases where there is differentiated thyroid carcinoma. Then, moving further, the comprehensive neck dissection or the conservative neck dissection for diseases with the involvement of neck, it is further classified into radical neck dissection and modified radical neck dissection. So the first one is the radical neck dissection. The radical neck dissection is the one in which the lymph nodes in the level 1, 2, 3, 4 and 5 are removed, along with the structures such as sternocleidomastoid muscle, internal jugular vein, and spinal accessory nerve, along with submandibular salivary gland. So, the indication of radical neck dissection is in cases where there is neck involvement for squamous cell carcinoma, where spinal accessory nerve is involved. Then coming to the modified radical neck dissection, the modified radical neck dissection is further classified into type 1, type 2 and type 3. The type 1 includes the removal of lymph nodes in level 1, 2, 3, 4 and 5. Sternocleidomastoid muscles will be removed, submandibular gland will be removed and internal jugular vein will be removed. But spinal accessory nerve will be preserved, and it is indicated in diseases with neck involvement for squamous cell carcinoma where spinal accessory nerve is free of disease, so there is no involvement of spinal accessory nerve. Then type 2 modified radical neck dissection, in this the lymph nodes in the level of 1, 2, 3, 4, 5 are removed, along with the internal jugular vein and submandibular gland. In type 2 modified radical neck dissection, spinal accessory nerve and sternocleidomastoid muscles are spared or are preserved. And type 2 modified radical neck dissection is indicated in diseases with neck involvement for squamous cell carcinoma, where internal jugular vein is involved but spinal accessory nerve is free of disease, or there is no involvement of spinal accessory nerve. Type 3 neck dissection or modified radical neck dissection involves removal of levels 1, 2, 3, 4 and 5, along with removal of only submandibular gland, whereas in type 3 spinal accessory nerve, sternocleidomastoid muscle and internal jugular vein, all these three structures are spared and preserved, and it is indicated in metastatic differentiated thyroid carcinoma cases. So, in the comprehensive neck dissections, radical neck dissection will involve removal of lymph nodes from level 1 to 5, along with spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle, and submandibular gland. Whereas in modified radical neck dissection, type 1, spinal accessory nerve is preserved. In type 2, spinal accessory nerve and sternocleidomastoid muscles are preserved. And in type 3, spinal accessory nerve, sternocleidomastoid muscle and internal jugular vein will be preserved, and only lymph nodes in level 1 to 5 and submandibular glands will be removed. Apart from comprehensive neck dissection and selective neck dissection, there is third type of neck dissection which is called as functional neck dissection. Functional neck dissection involves preservation of submandibular gland as well, and only lymph nodes in the level 1 to 5 are removed. This was first given by Boca, and it is indicated in patients with N0 neck, or in patients who have clinically no involvement of the neck. So this was all about neck dissections for carcinoma of head and neck. We'll see you in the next video. Until then, bye.